In the name of Allah, the most merciful and the most compassionate, a Prophet Muhammad, peace be upon him. My tutorial today is about ABR in clinical practice. The first comprehensive description of auditory brainstem response ABR in humans was Jawed. Auditory evoked potential or ABR auditory brainstem response or brainstem auditory evoked response assess the integrity of auditory system to the level of the brainstem. Auditory brainstem response for threshold detection using click or tone pairs, starting with high level down to threshold, and for neurological assessment by comparing absolute peak latencies, inner oral peak latencies, and inner peak latencies at low and high repetition rates. What's the possible retrocochlear signs? Raised or absent acoustic reflex, acoustic reflex decay, unilateral or asymmetrical sensorineural hearing loss. Conditions that may present an abnormal ABR. Central nervous system disorders like multiple sclerosis, unilateral or asymmetrical sensorineural hearing loss, acoustic neuroma or vestibular schwannoma with poor speech discrimination score, central auditory processing disorder, unilateral tinnitus, and auditory neuropathy spectrum disorder. Recurring evoked potential, proper care of the electrodes, and impedance are important because this is the medium for collection of evoked potential data. Inner electrode impedance is the most important one. What about the impedance? The goal is to have low electrode recording of less than 5 kilo each with no more than 2 kilo difference between electrodes. Keep in your mind, auditory evoked potential have very small voltage. It is measured in microvolt and are easy to be compromised by noise. So the noise might be physiological noise, eye movement, muscle activity, vascular spasm, vascular system, breath, alternating current 60 Hz artifact, and environmental noise. Test environment in quiet room, turn off unnecessary computer monitor, don't use cellular phone during testing, and turn off fluorescent lights. What about transducers? The best option for ABR is answer phone tubes. In some cases, we can use supra-oral earphone TDH39. The stimuli used: click stimulation, tone burst, and sharp. Click ABR is the standard procedure, but in frequency range 2 to 4 kHz, so best both low and higher frequencies. But tone burst ABR is a frequency-specific ABR. The typical tone burst correction factors: 20 dB for 500 Hz, 15 dB for 1 kHz, and 10 dB for 2 and 4 kHz. What about the stimulus polarity? We have alternating polarity, rarefaction polarity, and condensation polarity. The mature form of ABR at the mature form of ABR at 2 years or from 18 months to 2 years because of myelination and cochlear maturation. So ABR measures improve presence of response, waveform morphology, waves repeatability, and latency, absolute and inner wave latency. This illustrates the latency, amplitude, and waves. What about masking in ABR? In case of unilateral hearing loss with air conduction threshold for clicks, more than 70 decibel NHO. So the masking level is 50 decibel NHO. And we use masking also in bone conduction ABR as the bone vibrator inner aura attenuation is 0. So remember, avoid masking if masking is not necessary. This is a normal ABR. We can look here, identifiable, repeatable ABR waves could be traced down to 30 decibel NHO, reflecting normal hearing in frequency range 2 to 4 kHz. This is absent ABR waves. Non-identifiable nor repeatable ABR could be traced at maximal stimulation 90 decibel NHO. In that case, we have to do audioacoustic emission, we have to do MRI to show the integrity of the cochlea and the cochlear microphonics by ECOG. Threshold estimation hearing loss, in that case, identifiable, repeatable ABR waves could be traced down to 60 decibel NHO, reflecting moderate hearing loss in frequency range 2 to 4 kHz. This is a case of bone conduction ABR. Some difference between bone conduction ABR and air conduction ABR. The bone conduction ABR frequency range around 1.5 kHz. And also there is a latency shift than air conduction ABR 0.5 millisecond. This is a case of auditory neuropathy spectrum disorder, as we see here. Reflection click, reflection polarity, then condensation polarity when reverse polarity, then disappear the cochlear microphonic at alternating polarity. Another case of auditory neuropathy spectrum disorder, reflection click, reflection polarity, condensation, and disappear cochlear microphonic at the alternating polarity. That's traced by VivoLink or VivoSonic ABR, non-sedating ABR, the best ABR ever, the best non-sedating ABR in the market. Thank you for watching. Peace and Allah's mercy be upon you.